Hello everyone, today is a new day and with a new topic. Our today's topic is leprosy. Sometimes it is called Hansen disease. They call it Hansen disease. So what is basically leprosy or Hansen disease? This leprosy is basically known for its causative agent of this chronic inflammatory disease. It causes chronic inflammation, and it is caused by the microorganisms called mycobacterium leprae. It is its causative agent now, and it causes a different spectrum of disease, from starting from tuberculoid leprosy to lepromatous leprosy. In the middle there are some spectrums, we'll discuss it later, but it causes a spectrum of disease from the tubercular leprosy to the lepromatous leprosy. So let us see about the etiologic agent of the microorganisms. As I mentioned here, the microorganisms that causes the leprosy is Mycobacterium leprosy, and it is characteristically it is obligate intracellular acid fast stain rod-shaped microorganisms. It is obligate intracellular acid fast stained rod-shaped bacteria. It is bacteria, and this microorganism is basically characterized, or it is known for growing in the cold environment. It is characterized by the growing in the cold environment or in the cold tissue. So what are these cold tissues, the microorganisms that basically prefer? The first one is the skin, the peripheral nerves, and the anterior chamber of the eye, because they are cold environments, the upper respiratory tracts and the testes, because these are the colder part of our body, where their temperature is compared to the core temperature, they are very low. But areas which are warm areas like groin and axilla, they are just less likely to be involved. But the facial involvements and the facial involvements they are less likely to be involved. When you see about its incubation period, as I mentioned, it is a chronic inflammatory disease. It contains around 2 up to 5 years. 2 up to 5 years. It took a longer period of time. So there is no acute phase or acute disease in the case of leprosy. And its mode of transmission is usually by the respiratory droplet. Its mode of transmission is by respiratory droplet. Direct contact with persons usually it is less likely. And it is also a zoonotic microorganisms to be transferred. It has some zoonotic components, and the zoonotic microorganisms that is responsible for carrying this Mycobacterium leprae it is armadillo. It is a responsible microorganism that can carry this Mycobacterium leprae. So let's see about its epidemiology. When you see the epidemiology prevalence of this microbacterium, currently it is by WHO, it is stated as a neglected tropical disease. Neglected tropical disease, because it was announced that during the 2000 the Gregorian calendar, it was announced that eliminated public health problems. It is announced as an eliminated public health problem. But currently there are around more than 200,000 cases, new cases are per year documented annually, and more than 120 countries reported about the presence of these microorganisms in their vicinity. So it is a major problem, and currently it is still a major problem in countries like India, Brazil and Indonesia. They are repetitively reporting Indonesia and Brazil still reporting this Mycobacterium leprae as a major health issue or burdens to their endemic area. So it's still a major public problems. So what are the risk factors that can cause this Mycobacterium leprae? So the risk factors for the development of these microorganisms, the first one is as obvious ones, it is immunocompromisation. immunocompromisations. The other one is genetically susceptible individuals. Genetically susceptible individuals. These are and a close contact with untreated patient. So contact history. Contact histories, it is important for the development of this Mycobacterium leprosy. So what is the pathophysiology? So the first pathophysiology started from the entry of the microorganisms. As I mentioned before, microorganisms can be transferred from person to person from different mechanisms, but the currently well-stated mechanism is it is a respiratory droplet. So let's say the patient acquires these microorganisms via respiratory droplets, and the person acquire these microorganisms through broken skin or through mucosal skins, or from the sinusal tracts, or like nasal and oral mucosa the patient could acquire. So the main target for these microorganisms are two things. The first one is skin, especially the colder environments, the one that are stated here: skin, the testicles, the facial skin, the nasal area, the facial areas are the most targeted areas, as I mentioned here. And the other one is peripheral nerves. Peripheral nerves are the most responsible microorganisms of these things. From the peripheral nerves, the Schwann cells are the one that mainly attacked by these Mycobacterium cells. Schwann cells. These Schwann cells act as an insulator for the nerve conductions. It covers the microorganisms. For example, if this is the nervous system, this is the axon, the ones that cover the nerves, these are Schwann cells. Then, once the microorganisms enter into the cellular, it is an obligate intracellular. As I mentioned it is an obligate intracellular. So it starts to replicate inside the cell. So these replication systems can cause a death of some cells. So basically, there is a releasing of intracellular contents into the environment, which is a signal for the immune system. So the immune system will be activated. So activation of immune system. Activation of immune system will be the cause. Activation of immune system. So let's say the immune system is activated, but from different person to different person, our immunity system strength is different. For example, for a patient with HIV and with a normal patient, their immune system activation will be so totally different. So some people expresses strong immunity systems and the others express weak immunity systems. So some of them can cause strong immunity response, and the other ones cause a weak immunity response. So those who cause this strong immunity response, they contain the microorganism into a specific cells or in a specific area. So the damage of total peripheral nerve and skin involvement is minimal in the case of strong immune systems. So this type of microorganisms can cause later with these minimal lesions. They are also called a tuberculoid leprosy. And those who have this weak immunity response, they have this disseminated invasion. So they are disseminated, means a lot of space is involved, a lot of nerves are going to be involved because of this weak microorganisms, because there will be a spread of these bacterial systems into our systems, and this cause a lepromatous leprosy. They call it as this TT, and this one is LL, lepromatous leprosy, and natural. But if the immune system is between these strong and weak immunity systems, it causes a borderline leprosy, or they represent as BB. This will be the clinical manifestations of the microbe. So the immune system responses, the one basically decide the spectrum or type of the leprosy. So as I mentioned here, once the microorganism entered into the cell, it first attacks the peripheral nerves. So how the peripheral nerves are damaged? How they are damaged? How these peripheral nerves are damaged? So because of two things. The first one is there is a direct effect and there is indirect effect. In the direct effect, the microorganisms multiply inside the nerves, and in the direct effects, it is because of the immune system response. because of the immune system response. In the case of immune system responses, there is inflammatory responses. This inflammation basically can attack these peripheral nervous systems. So when there is repeated injury to the nerves, the final destination will be ulcers and deformity. Finally, ulcer and deformity formed. So ulcer and deformity would form because of there is a sudden swelling. Then the end step is, if the patient left untreated, the final destination will be lepra reaction. What is lepra reaction? So in the case of leprosy systems, there are two types of lepra reactions, which means our immune system strong immediately or suddenly get its own strength, and it start to attack our body. So it basically causes a severe destruction. Because of this lepra reaction, the patient may lose limbs and extremities, the patient lose digits, and the patient have these big deformities and ulcers. So what are these lepra reactions? We have two types of lepra reaction. The first one is a type 1 lepra reactions and type 2 lepra reactions. So let's us discuss some of them briefly. So let's here type 1 lepra reaction. So this type 1 lepra reaction, it is characterized by another type of it's hypersensitivity. It is a type 4 hypersensitivity reactions. So what is this type 4 hypersensitivity reactions? It is cell-mediated type of hypersensitivity reactions. There are immune cells which basically attack our systems, our body systems. They are called type 4 immune system. So it is cell-mediated immune systems, and it is basically responsible for the formation of this borderline tubercular leprosy or borderline leprosy or borderline lepromatous leprosy are mostly caused because of this type 1 leprosy reactions. And if it happens, our treatment or choice of management will be corticosteroid, systemic corticosteroid like prednisone. We have to provide, and we need to taper every month for the treatment. So we have it must be treated. The other one is type 2 lepra reaction. The type 2 lepra reaction is characterized, sometimes people call this erythema nodosum leprosum, ENL, erythema nodosum and leprosum. So they call it sometimes ENL. And this is also a type 3 hypersensitivity reaction. It is a type 3 hypersensitivity reaction. This type 3 hypersensitive reactions. This type 3 hypersensitivity is there is a formation of immune complex. And this immune complex deposited in different organs. So another immune system target these microorganisms because there is a formation of antigen antibody formations, and they are deposited. Same occurs like as PCG, one of the mechanisms. So there will be depositions and there will be hyperactivation of these immune systems. And the treatment modality, I will mention them in the lastly for the management parts, but in order to give highlights, these type 3 immune reactions must be treated with corticosteroid like prednisone and thalidomide. Thalidomide must be provided. So the treatment is corticosteroid and thalidomide. And this ANL is basically characterized for the formation of lepromatous leprosy and borderline leprosy is the classic features of this. So clinical manifestations in the case of type 1 leprosy reactions, usually they are asymptomatic, but in the case of this type 2 lepromatous leprosy, there is a full-blown fever, there is arthralgia, myalgia, joint pains, like the symptoms can be happen. So these are symptomatic type of leprosy reactions. So what are the classification of this leprosy? I have mentioned different spectrum. So what are the classification? So we have basically 5 type of leprosy reactions. We can mention here like this. The first, the middle one is there is a borderline borderline leprosy with the extremity of severe ones. There is a lepromatous leprosy and tuberculoid leprosy. In the middle between the tuberculoid leprosy and borderline, there is a borderline tuberculoid leprosy and there is a borderline lepromatous leprosy. There is a borderline lepromatous leprosy. So I have discussed them in different ways. In these cases, our immunity system is weak immunity system. We have weak immunity systems, but in the case of this, we have strong immunity systems, but in the case of this, we have borderline immunity systems. In these cases, high bacterial load, but in this case, we have low bacterial load. So determining the bacterial load also important in order to classify this type of microorganism. So but clinically practically it is very difficult and challenging in order to say it is either tuberculosis leprosy or lepromatous leprosy. So the WHO postulated another mode of classification. So let's see, this classification called immunologic classification. So the WHO classification is another one, and currently easier for application. So in the WHO classification, we have two types of leprosy. The first one is paucibacillary and multibacillary. So basically, the first thing is you see the skin lesion. If it is less than 5 skin lesions or if it is less than 5 nodules, it is paucibacillary. But if it is 5 and above, it is called multibacillary lesions. Simple like that. And you do smear, and if there is no smear, it is paucibacillary. But if you see smear this acid with acid fast stain, if you see obligate intracellular microorganisms, they are multibacillary. And if the patient have involved in nerve and ganglion, they are basically nerves are involved. So multibacillary is a kind of severity form of this paucibacillary. So what are the clinical manifestations? There will be hypertrophy of scars, there will be deformity of extremity, there will be nodules are formed, and there will be erythema. Are there the classic clinical manifestation of the patient? When what? Skin get involved. But when there is a nerve involvement, the clinical manifestation will be peripheral neuropathy, because the peripheral nerves are the one basically involved, because they have these cold extremities. They have this coldness. So which nerves are usually the most common to be involved? They are the hand nerves. They are the most common. What are these hand nerves? Ulnar nerve, median nerve, and radial nerve. But also the posterior tibial nerves and the fascial nerves also involved. So there are fascial nerves and posterior tibial nerves also the most common site of to be involved. Another sites are, as I mentioned before, for example, the site to be involved like that is the testicles. If the testicles are involved, there is with testicular atrophy. If the anterior chamber, because another site will be testicle. So if the testicle is involved, there will be testicular atrophy. If the eye is involved, there will be keratitis or iritis, inflammation of the eyelids. Yes. If the nasal mucosa is involved, there will be nasal mucosa lesions, skin lesions might be visible. So how do you diagnose this leprosy, or what are the modality for the diagnosis of this leprosy? So there are cardinal signs. There are cardinal signs that are basically responsible for the diagnosis of leprosy. They are traits. You can mention the traits. So the first one is if the patient have this hypopigmentation, or there is erythematous or red patch and nodules, and peripheral neuropathies like sensory loss. It is one criteria. So there may be hypopigmentation, or there may be nodules, or there may be red patch, or there may be sensory loss. This is one criteria. The other one is if the patient has thick peripheral nerves, whether it is sensory or motor. So thick peripheral nervous. So when you are evaluating the patient, if you see ulnar nerve or radial nerves got hypertrophied, and if you are palpable from the physical examination, there are one criteria. And the other most important is there is a positive slit or acid fast state. So there is a positive slit test, skin slit test, or acid fast bacilli. You take a sample from the earlobes and you put it on a slide, and if you see these acid fast microorganisms, the likelihood of being leprosy is high. So how do you treat management, or how are the treatment managements of the leprosy? So in the case of leprosy, whether it is PB or MB, our mode of treatment is the same. The only difference is the duration. So we are using a multi-drug therapy. So if it is PB or Pauci bacilli, our treatment will be rifampicin and dapsone. So rifampicin 600 milligram PO every month for 6 months is provided, plus dapsone 100 milligram PO. It's orally treatable. PO daily for 6 months. This is the first treatment for PB. And for the case of MB, our treatment will be rifampicin 600 milligram PO every month for 12 months. But the dapsone stay the same. Dapsone 100 milligram PO daily for 6 months will be the management nature. But another most important difference from this PB, in the case of MB, we have additional three medications. It is clofazamine. So there is rifampicin, there is dapsone, and there is clofazamine. Clofazamine 300 milligram every month for the 12 months. But the difference is, again, we are giving this clofazamine 50 milligrams daily for what? For 12 months. So every month we are giving them 300, but every month we are giving them 300, but daily we are providing these clofazamines 50 milligrams. So we are treating with 3 medication. You can say this as a 3 medication because we are providing them different doses. They are the same. In terms of type of medication, we are giving the rifampicin, dapsone, and clofazamines. But in terms of dosage, we have 3 routes. And the other most and critical important in the treatment of this leprosy is treating of the lepra reactions. I have mentioned before, but in the case of lepra reaction, in the treatment of lepra reaction, we are for type 1, the treatment choices, it is prednisolone. For type 1, for type 2, the treatment choices, it is corticosteroid plus thalidomide. Thalidomide will be the thalidomide plus prednisolone. So we are providing these both things for these patients. So the most important thing is following. This rifampicin is known for what? Hepatotoxicity. Dapsone is known for skin pigmentation, and hepatotoxic glucose. Dapsone is they are very sensitive. They are glucose 6 DP sensitivity. So you need to follow the CBC. You need to follow for the CPC when you are providing the dapsones, because the patient is at risk for developing of this hemolysis, glucose 6 GP problems, and clofazamine is known for its hyperpigmentation. So these are generally all you need to know about leprosy. Let's move on to another microorganisms.